Hello, welcome back. Welcome back. I hope you got some good time for networking and catching up with some new people, making some new connections. Um, uh, we're going to move on to our first session. I'm going to introduce the chairs just in just a second, but I want to make sure that you all have the Chime platform open. It needs to be on the green page, which is the landing page, when it gets to the voting. Another tip is that this does use quite a bit of battery, so there are charging stations everywhere, so just keep an eye on your battery as well. So without any further ado, I've already introduced our conference co-chairs. I'm going to hand over to Dr. Ben Stanger and Dr. Nilo Azad, who are going to take us into the first session.
Well, good morning, everyone. Oh my goodness. Good morning, everyone. On behalf of Ben and I would like to welcome you to this first consensus conference and to the first working group. And we're so excited for the work that we're going to do together in the next few days. I'm going to start by introducing Leslie Swanson, who is on the Nursing Advisory Board for the Cholangiocarcinoma Foundation, as well as Bruno Odisio, who is a professor of radiology and the head of the Department of Interventional Radiology, and a maverick and leader in the field at MD Anderson. And they're going to start us off with the first working group.
Oh, great, thank you so much. We will get started here. This is looking just a quick overview of our agenda. But this is just an overview of our working group. So our co-chairs were Dr. Simon Rushbrook and Dr. Bruno Odisio. And our group consisted of radiologists, interventional radiologists, hepatologists, medical oncologists, bioengineering, and nursing.
Thanks so much. Good morning, everyone. It's a real pleasure to be here. I just want to give a brief introduction about what were the themes that we initially planned to discuss today. And it was essentially on our first meeting, we tried to break between diagnostic innovations and biomarkers, therapy allocation and clinical guidance, and immunotherapy and radiomics integration. And after a few rounds of discussion, some of those themes, they were moved to other working groups. So we're going to discuss those in the next following working groups in the next following days. And that's where we are focusing the discussion today. The ones highlighted in yellow: optimal biliary decompression, imaging biomarkers to aid early diagnosis of cholangiocarcinoma, and imaging biomarkers and its interplay with radiomics. So with no further ado, we're going to have 4 presentations today with voting after each presentation. We're going to start with radiomics, and that's going to be presented by Angela Mirabili and then Alejandro Fornet. Thanks so much.
Good morning, everyone. It's a pleasure to be here to present the latest advancement in radiomics in cholangiocarcinoma. So, first of all, what is radiomics? Is the throughout extraction and analysis of quantitative feature from scan. This is really a difficult definition, but essentially is the possibility to extract some features that are invisible to the naked eye from the medical images that can be from CT, MRI, or PET-CT. And we can have these features based on tumor size, tumor shape, tumor intensity. And then these features are, so we transform the imaging into data that are further processed into some, with statistical analysis into models, so that are used for diagnostic and prognostic purposes. The main advantages is that we can have the possibility to have biological information of this tumor without the need for a biopsy, so a complete non-invasive method. This is a general overview of the AI application in cholangiocarcinoma, but I would like just to focus on the possibility to improve the image quality and also considering the general approaches to artificial intelligence models, just to understand that we need a lot of data, because we need significant data partitioning into training, validation, and testing data set. This means that we have first to teach to the model what he has to first to teach the model, then to validate to prevent, for example, overfitting, and then to test to new unseen data. I think that this slide is particularly significant because one of the main advantages of radiomic is the possibility to capture the tumor heterogeneity. We know that cholangiocarcinoma are heterogeneous tumors. Sometimes this heterogeneity is not revealed by biopsy. This is the reason why radiomics can evaluate the whole tumor, so supporting also a more detailed prognosis evaluation, knowing that the higher heterogeneity has been correlated also with poor prognosis. Now I would like to show you the typical flow of the radiomic process. This process starts with the identification of the region of interest, so the so-called segmentation. And this can be performed manually or with automatic tools, as I will show you later. And then after the identification of this ROI, we can have the extraction of radiomic features. These radiomic features are then used to build the model that can be prognostic, diagnostic, or with radiogenomics models. And eventually, they can be also correlated with the clinical data according to the aim of our study. This is just an example of the tool that is called the Total Segmentator. It is an automatic tool for segmentation of every organ in our body. And the idea is that we can always perform manual segmentation, but it can be subject to interoperator variability, or, for example, it is a time-consuming process, especially for the larger lesion. So among the advances in the radiomics is the presence of these segmentation tools. Finally, this is a quite difficult slide because it describes the type of radiomic features. Just to tell you that we have different orders of features, from the simpler one that are called the shape, so strictly related to the shape of the tumor, to the most difficult ones that are called the texture features or second-order features that evaluate the single voxel and also their relationship. So if the single voxels are more similar or they are really different, and they can be the mirror of the heterogeneity of the tumors.
Finally, we decided to look for the literature regarding the applicability of the radiomics in for cholangiocarcinoma. In this slide is very busy, but I'm not going to enter in detail. But there are several applications that we will basically discuss. Two most important applications. Radiomics has been used to identify the tumor heterogeneity, the tumor subtype, the presence of microvascular invasion, neural invasion, but we think that there are two clear applications for the radiomics. The first one is to differentiate cholangiocarcinoma from other lesions. We think that this is a relevant clinical question that radiomics can be faced. Here I show you the main literature that we have identified in the PubMed. As you can see here, all of the studies come from China and from Asia. And I will just only to highlight that the accuracy of the current radiomics models is not perfect at all. The best sensitivity and accuracy is around 80%, and we think that radiomics needs to be near 100% to be clinically to be applied in the clinical practice. And another interested application of radiomics is the detection on lymph node. As you know, lymph node presence is critical to make the prognosis of our patients and to decide if the patient is resectable or not. And again, there are a lot of literature testing radiomics for lymph node detection. Again, I'm not going to enter detail with the literature. We have to recognize the potential caveats that we have with radiomics, and we have summarized in a very simple way in three parts. The first limitation is the algorithm perspective, how we retrieve the data from radiology. According to the technique that you use, you may have a different output. Another important point is the clinical perspective. I'm a clinician, and when I analyze the radiomics papers, I always try to answer myself if this radiomic application is clinically relevant for me. And finally, and I think the most important thing is the social perspective. You know that radiomics is now growing up. There are a lot of machine learnings and all the ChatGPT and so on. But I think that we have to face the transparency, to face the accountability, and also to face the ethical concerns that we have to face to use radiomics in the clinical practice. And finally, and probably this is the most important point in radiomics, okay, there are a lot of literature evaluating several radiomic tools for all the clinical aspects of cholangiocarcinoma, but probably the most important point is that we don't have validation studies. As I have said, there are several techniques to retrieve the data and to analyze in the machine learning, but we have to be sure that this data is reproducible, and we have review all the literature, and the main concerns that we have, the panel have, is that there is very few data of external validation of the models, and this is a score that is used to validate, to evaluate the reproducibility of the models, and I can tell you that most of the papers that I have shown before in the slides, they don't have an external validation, and this is clear. This slide try to face that the external validation is critical to approve the use of radiomics. And another point is, okay, perfect, radiomics is very useful, or maybe very useful, but you know that the radiology is very complex. There are several radiological tools, CT scan, MRI, ultrasonography, and even CT scan and magnetic resonance. There are different techniques, contrast agents, and it's very important to try to fusion all this information in radiology, to use different techniques, and to be able to have a radiomic tool that can fuse the techniques, but also as a clinician, I will ask also the radiomics to merge all this radiological information with clinical information. And finally, another potential perspective for radiomics is perfect. We have not only a baseline tool to identify lymph nodes or to identify the diagnosis, but also may be helpful to follow the patients and to assess the tumor response of our patients. And that's also my last slide. And Angela, I've invited you because you are the author of this slide. No.
This is just a summary of what we have already explained. So the current application, also the clinical gaps, so for example, the lack of external validation, the new perspective, so thinking about the virtual biopsy or the analysis of the non-tumoral parenchyma, and for also the future advances. So also the possibility to have a better clinical impact, and nothing. Just a summary to convey the main message of the application of radiomics in cholangiocarcinoma. No? Okay.
Okay, so here we are at our first voting statement for radiomics. Development of AI imaging interpretation of cholangiocarcinoma for diagnosis to identify tumor heterogeneity and adverse factors such as lymph node status, microvascular invasion, perineural invasion is a research priority.
So if everyone can log into their chime, as we did in a practice session, and we'll start the timer.
Right, so we have about 50 seconds. I think this is a very general statement, but the idea here is to raise awareness about the possibilities that we have with radiomics. And I think we're going to see what kind of resources we have currently available on the next presentation, the final presentation with Vincenzo Cardinali.
Last couple of seconds. So we have consensus.
Now we'll move on to the next. Okay, so next to talk about biomarkers, we have Dr. Michael Goggins.
Good morning, everyone. So we have imaging-based biomarkers. What about other types of biomarkers? So mainly blood, but also handling biopsies and bile. So most of this will be about blood-based diagnostics, and so tremendous progress has been made in this field across cancers in general, and several studies have addressed cholangiocarcinomas. So we've had next generation sequencing going on for over 15 years as a tool that's moved into the clinic. But what about next generation DNA-based testing? So the figure shows different kinds of DNA abnormalities. Most of the work has been on either mutated or methylated DNA. The kind of methylated is the Galleri test and mutated Gardant, for example. These are tests that are available clinically. What's important about them is even though we're detecting mutations in many patients with cholangiocarcinoma, the signal is low in the blood often. The results tend to be more prognostic, as if it's a reflection of micrometastases, so not always early enough. But of course, given the diagnostic uncertainty that exists when many patients present with abnormalities that turn out to be cholangiocarcinoma in the workup, using blood-based testing for diagnosis does have a lot of promise, and it really hasn't been realized very extensively. The Pathfinder follow-up, for example, looked at symptomatic patients, the UK-based study where they showed that you could use a DNA methylation-based test ctDNA-based test to detect evidence of suspicion of cancer, and that did include patients with hepatobiliary cancer, but this has not been extensively looked at. So, can you actually facilitate diagnosis with ctDNA? And again, the current tests, as good as they have been somewhat imperfect in that you still sense that there's a low signal. I point out some other kinds of, in the figure you're seeing the changes like chromosomal rearrangements. So the more information you're getting about the blood circulating DNA, the more you can see abnormalities. So for example, it's easier, it looks like, from the technologies to see evidence of gains and losses in chromosomes, big chunks of DNA, as opposed to looking for one mutation or a small number of methylated DNA changes. So there are methods that are being developed that are trying to move past the current limitations of ctDNA. One of the challenges, depending on the method, is that, for example, a mutation doesn't mean that you have, cancer. There are other reasons why you might have blood with DNA abnormalities. For example, in the blood compartment itself, the blood cells can have genetic alterations, so-called clonal hematopoiesis. So These tests are not always specific. So a tremendous amount of work has been done in working up certain methods, but not some of the next generation methods, especially the ones that look at aneuploidy chromosomal changes. There's a lot of interesting work on how the DNA is fragmented. That tells about the gene expression of the cell, or what is being shed. So there are these interesting areas where the technologies could be compared. And on this list, you have all these different technologies, but have they been compared head to head? So you can have these bake-offs whereby you have a reference set of samples from a good number of cases and controls that could be applied to other specimens. But this is a very useful way to have a head-to-head comparison, try to understand exactly what test is being done, because in any one study, the patients will differ, the tumors they have may differ, the kind of controls that are used to compare will differ between studies. And so the comparison between studies can be challenging sometimes. Moving on, this gives you an example. This was a multi-center study published a couple of years ago. Dana-Farber and MGH, other groups. And 80% of patients with cholangiocarcinomas had a detectable ctDNA. Some of these are actionable, so they're very important if you detect a targetable, FGFR, whatever the treatment, the target might be. But often there's only 1 or 2 mutations found, and the cholangiocarcinomas often have more mutations than that. So again, there's this sense that we're not detecting enough. With the detection, as I mentioned, so far when we're detecting ctDNA, it tends to be, it's not that we can't detect stage 1 cancers, but they're much more often are the cases that are more advanced stage or will have a poorer prognosis. This is a paper that just came out recently, for example, showing the positivity being associated, even in early stage cases, with a more poor outcome. So we need to do better at finding strategies, at taking advantage of the newer technologies that are available to really interrogate CT circulating DNA more closely. These blood-based biomarkers, ctDNA, do better than the old conventional protein markers like CA19-9. These are so-called ROC curves. If your curve is in the right, a perfect square on the right, it's a perfect marker. If it's more of a straight line, it's not good at all. One thing to say about that is that a lot of the protein markers that are analyzed, and this is especially true of CA19-9, this is from our own work, is that there's a lot of individual variability. Sometimes that's, as in this case with CA19-9, it's related to genetic factors. So understanding a person's biomarker and how it behaves over time. So what you'd like to see, for example, patients with PSC who are going to be under surveillance, having many years repeated markers being done regularly to understand where they're at normally, because there can be a 10-fold range in the normal range. And this is not really appreciated in the standard testing. And so personalizing even the simple markers like CA19-9 has unrealized potential, certainly worthy potentially of investigation. What about evaluating then brushings and biopsies? So a major challenge is patients who have a stricture in their common bile duct, and it's suspicious. Obviously, in the case of PSC, for example, where are we at? Can we apply better biomarker technologies? This is a paper from a few years ago from Torresinghi et al. At Pittsburgh, and they had a test called BILI-seq, essentially a mutation panel, and they showed that it improved upon using cytology and brushings. And in his hands, it was pretty specific as well. So this was evaluating tissue samples, biopsies, or brushings from patients undergoing ERCP with strictures. You can be concerned, and obviously the imaging we want to do better, but it's surprising how often the biopsies, even with the spy glasses, and fail to get a diagnosis. So there is certainly room for improvement. This was followed up by a validation study with the same method, and similar results. Not 100% perfect. I mean, the detection mutation doesn't mean cancer. But again, applying additional technologies, not just the straightforward, let's look for mutations, but let's look for other kinds of genetic abnormalities or other kinds of abnormalities in the DNA associated with cancer, holds promise to take these precious samples. A common approach is to use, besides the cytology and brushings, is to use FISH, look for chromosomal abnormalities, and when you combine FISH with next-gen sequencing, each iteratively improves. Cytology and biopsy has limited ability, tremendously limited ability in the setting of PSC-related cholangiocarcinoma. So adding these together helps, but again, can we do better with not just looking for mutations, but looking for the kind of the next generation of abnormalities that the technologies are available to do this now. And then finally, bile as an aid to diagnosis. Not a whole lot of work published on bile. This is an example of patients with indeterminate strictures, a paper from got from a Spanish group a few years ago, which really showed that cases that were, both cases that were considered benign and that turned out to be malignant, and in cases that were indeterminate, that a bile DNA profile, much like you get in the blood, except the DNA fragments are there. It looks like there's more mutated DNA, more cancer DNA. The fragments are kind of larger. It's a rich sample. Obviously, a lot of these patients are getting bile sampling as part of their workup. So there's unrealized opportunities as of yet. Not a lot done on biomarker profiling using next generation and next generation, next generation. So a few voting statements. I guess they're all listed in one slide. So I guess we have to do this one at a time. So the first statement, a general statement, blood-based biomarker tests continue to undergo evaluation and refinement and merit further investigation for their potential diagnostic utility in patients with cholangiocarcinoma. So that's the first one.
Thanks so much. I will interject here. We have about 60 minutes on this session. We are done pretty much with half of the presentation, so thanks so much for being on track. Would like to open, before we vote, if there are any comments, any questions from the audience about this first statement specifically, and we can do the same thing for the other statements that will come, because I think we are relatively well with timing, right? Yes, I got the approval here. That's great.
Could we quickly go back to all three to see them against each other? The slide, 2 slides behind. Just take a minute here to...
We have someone on the microphone 4, if you don't mind. You might introduce yourself and ask the question.
Thank you. My name is Matt Nestor. I'm Vice President of Patient Advocacy at Partner Therapeutics. My question regarding the first statement is, while generally I support it, I do wonder if it minimizes the potential importance of RNA-based NGS to detect rare fusions. Maybe, certainly not intentionally, but that's my one question. Thank you.
Yeah, and that gets to RNA fusions, of course, are fusions that are in the DNA that can be detected potentially with RNA more easily. So there are, again, this speaks to this general next generation. So not meaning to exclude novel technologies. RNA-based technologies in the blood have been significantly understudied. So I would put that in, again, the next generation bucket. That there are these technologies that have not been applied to evaluate patients with cholangiocarcinoma.
Right.
I have a quick question. why did you limit your statement to the diagnostic potential when in your presentation you were talking a little bit more about longitudinal surveillance, and of course we want to have pharmacodynamic, we're going to have predictive of toxicity, so we want to have biomarkers across the spectrum, but you've specifically focused on diagnostic. Can you just comment on that?
And forgive me if that was the charge. Certainly biomarkers in the blood, ctDNA, is being used clinically for clinical decision-making to guide management, to understand prognosis serially over time. And, that's for sure. And the better the technology becomes, the more likely we're going to see, fusions, resistance, mutations. Though that's all for sure. We're kind of limited to certain number of voting statements. So it's certainly important for sure.
All right, so let's go to the voting now. So I'm going to repeat the question. Blood-based biomarkers tests continue to undergo evaluation, refinement, and merit further investigation for their potential diagnostic utility in patients with cholangiocarcinoma. If you can start the clock, please.
Can we start the clock?
We're waiting for the push. Once it comes in, then the clock starts.
Technical hitch.
At least was not in the first one. So.
So just to quickly say that we all get a push, and only then can the clock start. So we're just waiting for the push to come, and then we can start the clock.
Do you have a question at microphone 1?
Microphone 1.
Does it work? Okay. I'm going to introduce myself. I'm Angelo Pirozzi, oncology fellow from Mayo Clinic, Arizona. And I have a question regarding the use of ctDNA for the detection of recurrence. There are studies in other types of disease, like breast cancer, when we detect on ctDNA recurrence or like a targetable alteration before the CT scan finding, it's been demonstrated that the changing therapy at that moment can improve progression-free survival. Do we have studies like that in cholangiocarcinoma? For instance, let's say studies that are evaluating changing therapy when I found an FGFR2 alteration together with the recurrence on ctDNA, but the CT scan is still negative.
So the push has come. I suggest that we vote, and then if there's questions about the wording, that can be addressed subsequently.
Okay, please vote.
All right, we got consensus again.
So maybe just we should allow an answer to the question if you can restate it.
Yes, so your question was about the herald that ctDNA could have over imaging. And that has been shown in certain cancers. For example, colorectal cancer was an early cancer. 3 months, potentially more, ahead of an imaging finding, the ctDNA could emerge as a signal of recurrence. And I haven't seen papers on this subject. A related question is, well, what do people do, for example, if they are doing serial ctDNA doing surveillance and you're on a targeted therapy? There have been papers, the resistance mutations to, let's say, a kinase, domain mutation in an FGFR, and that will, I think, cause clinicians to adapt. So certainly, more work. Those are obviously very important studies, but I have not seen that specifically about, heralding recurrence in the setting of cholangio. So it's a relevant topic.
Thank you.
Okay, so we'll go to our second voter statement for this for biomarkers. And this one says, bake-off studies or head-to-head comparisons of multiple biomarkers using reference set blood samples are needed.
Michael, do you think you need to elaborate more on that statement to help the audience, or?
Yeah, so this was the idea that one of the ways of advancing biomarker studies, this is more in the diagnostic realm, but in particular, but taking one technology that's well studied, published, and comparing it to another's technology. It's not common in a field that you compare these head to head. And that becomes possible when researchers and patients are donating blood specimens or other kinds of specimens, and so that investigators can blindly go off and, all right, someone knows the ground truth, we're going to send this, see how good your test is. A bake-off is one way of calling that. And so that kind of approach where the investigators, along with the patients, develop studies so that we understand and compare the performance of the best performing markers against each other.
So I have a question which is sequencing the recommendations. So doesn't this presume that you have two competing highly viable assays to begin with? And probably we haven't crossed that threshold yet. Yeah,
well, it's even comparing your CA19-9s direct, but it's more about if you have. I mean, there's many different methods of doing mutation detection in the blood. There is methylated DNA detection, copy number detection, and not necessarily even the same method from different labs, but different technologies. And this is not something that could easily be done today, but I think it's as a field being able to get or organize around this concept so that you're planning these kinds of studies.
So it becomes a matter of still of sequencing. If we're not ready today, is it a priority today? And you're arguing that's moving in that direction from an organizational perspective has utility.
Yes, I would say that if you asked Grail or you asked ClearNode, you asked Guardant, you had a reference set. If you had some of these stakeholders together to do, and you had reference sets, that would be very valuable to the field.
Yeah, so it may be that the studies per se will be needed in the future, but the priority now is to begin some sort of organization or biobank.
Correct. Exactly. Yes. So to get that underway would be valuable to the field, I think.
So this might be an excellent way to vote in terms of agreeing or disagreeing. Not that I'm trying to tell you what your vote is going to be, listening to you, and then we can kind of discuss why we might want to disagree or agree.
Yeah, right. Because the question should be rephrased from my perspective.
But I do think Dr. Goris brings up an important point that this consensus conference is about setting research priorities, not just for today, but for the next few years. And so just to keep that in mind as we vote. Dr. Ronconi has a comment?
Well, I think it was very in line with what Gregory has said. I think I absolutely agree we need some new biomarker, especially from a diagnostic perspective, but I think we are jumping a step here because we don't have now a reference biomarker to make an head-to-head comparison. And I would probably discourage you to say we need to compare with CA 19.9, as I think as a clinician we tend to say, to discourage everyone to use that as a diagnostic biomarker because it doesn't have the sensitivity and the specificity good enough. So I'm a little bit, probably I would like a rephrase about that.
So I'm going to make a recommendation that we go ahead and vote, and then we can continue discussion on this point and others depending on where we are in terms of consensus.
People are voting. For those who have already voted, I would use this time to think about how you might revise the statement to reach consensus. If consensus isn't reached in the initial vote, think of what you might want to say.
Okay, so we don't have consensus on this, and so I'm going to open up the floor for any comments. And I'm going to take chair's prerogative if anyone steps up to the microphone that I also disagreed with this consensus for a couple of reasons. I think the comments that were just made are very astute. The bake-off study is a great metaphor, but I do think there are challenges considering these are being developed by industry partners who already find themselves in a competitive posture, and I'd love to take that competitive posture out of the recommendation because I think we want to encourage collaboration, which is hard with industry partners sometimes because they have bottom lines that they're considering. And I also think in terms of rephrasing, as Dr. Sanger mentioned, perhaps head-to-head comparisons of multiple biomarkers as these assays mature may be needed, something that speaks to the fact that we're not there yet.
Yeah, I would just add that one, it's not just industry, right? There are academic partners as well, and yeah, it's by no means do we have a gold standard, but it's a rare cancer, and so getting academic and industry working together, it's a process. So I mean, it's a general statement. I understand. So.
Maybe if I can add a comment. I mean, just reflecting the comments from previously, I think maybe the first step is establishing that reference set,
yes, that's
which
exactly
we know
right.
is validated, accepted.
That's the first huge part.
And then move on from there. So maybe establishing a reference set of blood-based biomarkers.
Yeah, might have been a better way to phrase it, with the goal to bake-offs. Yes.
Multi-center.
Microphone 3, sorry.
Hi, everyone. My point was, I think, really along those lines of what's the infrastructure we need so that we can have the samples needed to actually accurately evaluate these biomarkers as they come forward. And I think it would be a wonderful thing to do for the foundation and other partners to actually fund the establishment of the infrastructure. And I think of it in really two different dimensions. There's the, first what in biomarker studies they call a phase 2 study, where you're just doing a case control. So you have so many cases, so many controls, and you compare the performance of biomarkers along those lines. And so for that, you need sort of a case control data set or a biorepository. But I think also really important is that when you have people who are at risk for cancer, the cancer develops over time, and it's really helpful to think in the phase 3 context where you take people at high risk, develop a prospective registry, and that allows you at some point in the future to actually take a look back and say, when we apply this biomarker, how much in advance of the clinical detection of the cancer does this biomarker detect the cancer? So I would propose that we actually think about trying to fund maybe a multi-center establishment of both types of registries.
Dr. Ilyas?
So when I saw the 3 priorities, or I think it was recommendation 2, 3, and 4, what I wondered was whether recommendation 3 could be weaved in with the prior one, because that was blood-based markers, right? I wasn't fully understanding why we needed 2 different ones, because if you establish the biomarkers, you could have it be a 2-fold priority, where now you've established it, and once you have, you know, reference biomarkers, then you can conduct the bake-off study. So it wasn't really clear to me why this had to be a separate recommendation. And then I do have a question on the process. I mean, if there's any modifications, are those going to be made real time?
Yeah, in fact, I think it's a really good point. We are trying to write another question, another voting statement. So what we have in mind for now, and we want to hear from all of you, is establishing a reference set for blood-based biomarkers as a diagnostic tool and longitudinal surveillance method, to keep in line with the comments from the prior gentleman, is a research priority as a first step before head-to-head comparisons are made. It's a very long statement. I might need to repeat myself, but someone can write there and modify it. Okay,
yeah, I can also just briefly address the prior question. I think it's a fair point. The first statement had to do with there's still a need for those, you know, initial significant publications on, you know, next generation. Bake-offs are often comparing published biomarkers head to head. So it's like one is one phase and then one is the next phase. But yeah, they're related.
We are over the halfway mark of this session, and we still have 5 recommendations to go. So I'm going to ask for us to vote on this revised recommendation. And I think this conversation is very interesting. We can continue it after the session.
I'm going to read again. They're modifying the question, but I'm going to read once again. Establishing a reference set for blood-based biomarkers as a diagnostic tool and longitudinal surveillance method is a research priority as the first step before head-to-head comparisons are made. Am I missing anything? One? No.
Thank you. Just while we wait, if anybody's having any tech issues, please feel free to pop to the registration desk. There'll be people there to help you. And we're just building that question now.
That's the magic of a Delphi consensus. That's how it goes. You know, it's back and forth. We're going to get there.
So So the wording that you see there is a little different from the wording that Bruno just offered, but I think the sentiment is similar and we can adjust the wording a little bit.
We're just waiting for the push. The push has arrived.
That's the magic.
So let's move on to the next recommendation.
So I can read, the last one is further evaluation of bio-based and cytology biopsy biomarkers in patients undergoing evaluation of biliary strictures are needed. I think Dr. Goggins wants to touch on the matter that when we do biliary drainage, there's a very rich potential use of the bio, and we typically, at least in my institution, we just collect samples for microbiology. We don't collect any samples for cytology and bio-based biomarkers.
Yes, it's challenging enough when you have a stricture to have delayed diagnosis, and bile is likely to be rich, and it's certainly has been understudied in my view. And also, again, next generation, I've merged the two to try and cover them both, but because there's similar challenges. We could be applying our next generation tools, if you like, to these difficult cytology specimens of people who have strictures with uncertain, that could be cholangio, we're not sure.
All right, so we can vote now. Yeah, move to the next slide.
Push has arrived.
All right, thanks so very much, Dr. Goggins. I think it was a really good session. We're going to keep moving here. We have 33 more minutes for this working group. The fourth part of this agenda today will be discussions about malignant biliary decompression. That was presented, actually the slides were made by Dr. Irene Bargelini from Candiolo, University of Turin in Italy. Unfortunately, last minute she was not able to join us, so she recorded a video, and between her, myself, and Dr. Terence Gay, the three interventional radiologists from this working group, will try to answer any questions that might arise. So if we could play the video.
So, welcome, dear colleagues. First of all, my sincere apologies for not being able to join you in this meeting. My name is Irene Bergellini. I'm an interventional radiologist working at the University of Turin, and it is my great pleasure to share with you our thoughts regarding the topic of biliary decompression, which is often neglected when it comes to research, despite its very important role in terms of clinical management of our patients. So let's start with just some considerations. First of all, we know that biliary decompression is quite important when it comes to patients with biliary obstructions, particularly higher biliary obstruction. It has specific advantages in order to reduce perioperative complications, reduce operative time, improve nutritional status, and also allow for chemotherapy. However, it has some drawbacks related to potential complications, mostly infections, but also bleeding and seeding. And ultimately, the real problem is that we really don't know whether biliary decompression and how biliary decompression could impact on patient survival. So we had a few talks about that, and we decided to just point out a couple of issues regarding both indications and technique. First of all, indications. We know very little about which patients do really benefit from percutaneous biliary drainage. This is just a recent meta-analysis, and first of all, you will notice that there were only retrospective studies. More than 3,000 patients included in this meta-analysis comparing percutaneous biliary drainage or not. And what they show is actually percutaneous drainage is able to reduce the risk of hepatic failure, which is quite very interesting finding. And also, however, at the price of increased perioperative morbidity and therefore also longer hospital stay. Although these differences are less dramatic when it comes to very well-selected patients. So the conclusion of this meta-analysis is that PBD is not routinely recommended, but it could be recommended in patients with high bilirubin level or specific situations, such as malnutrition, or maybe patients who are selected for portal vein embolization prior to resection. How do we select, however, patients who really could benefit from PBD? To be honest, we don't have objective parameters, but as a radiologist, I found quite interesting this study talking about MR elastography. The authors proposed a model coming from 3 different parameters: shear stiffness, loss modulus, and damping ratio. And this specific model is able to accurately identify patients with obstructive jaundice, differentiating them from patients with liver fibrosis. And most of all, it's able to discriminate between mild and severe obstructive jaundice. Now, what's important is that these parameters could also serve as parameters in order to select patients with severe obstructive jaundice who will actually benefit from biliary drainage. Because what they show is that this model correlated quite nicely with those patients that after biliary decompression actually had a successful procedure in terms of decline of total bilirubin within 7 days. And the accuracy was more than 90%. So this is just an idea on how we could use non-invasive modalities in order to quantify and also to monitor the change of specific parameters and to define whether a procedure is indicated and in the setting of indications, even if that procedure could be successful. The other big topic is technique. Well, first of all, it's not really clear when we should perform percutaneous or endoscopic drainage. For instance, the endoscopic guidelines tell us that ERCP is indicated for bismuth 1 and 2, and this is quite straightforward, whereas PTB could play a role together with RCP in bismuth type 3 and 4, according to local expertise. Now, if you take a look at the images, you immediately understand that there is a whole area related to hilar biliary obstruction that is a sort of gray area in which things are not really clear. And in fact, if you compare different guidelines, you will see these differences. The ESMO tell us that percutaneous should be indicated only basically after failure of contraindication of the RCP. The American guidelines tell us that endoscopic should be preferred in the resectable setting, whereas endoscopic or percutaneous are good enough in both good enough in palliative setting. However, if you take a look at clinical practice in this European survey, it appears that indeed percutaneous biliary drainage is very widely used also in resectable patients. Regarding the literature, in this systematic review, first of all, comparing percutaneous and endoscopic biliary drainage, first of all, again, no high-level evidence. Most of the studies are cohort studies, and the authors found only one randomized controlled study. What they show in this systematic review is that PTBD is indeed associated with higher clinical success rate and lower rate of cholangitis after drainage, similar technical success, similar rate of postoperative complications such as seeding and bleedings. However, as a whole, if you take a look at the literature, what is true is that both ERCP and PTBD carry the same problems, and most of all, the fact that patients die early after drainage, within 6 months, without ever receiving any cancer treatment, mostly because of cholangitis. With this observation, these authors, the group from Rotterdam, postulated that the main problem is infection, and to reduce the risk of infection, we should avoid during drainage crossing the ampulla. And this is why they came out with this new technique, which is called primary percutaneous stenting. Basically, without crossing the ampulla in unresectable disease, they do primary stenting and they don't leave any external drain, and they seal the puncture tract right after the procedure. And this is how it looks like. In this case, bilateral stenting, immediate stenting, no crossing of the ampulla, and sealing of the tract. What they did was this Tesla pilot study carried out in the Netherlands, phase 2 multi-center trial, including only unresectable disease with hilar obstruction of the different type of disease, no earlier drainages, primary percutaneous stenting with self-expandable stents, and the primary endpoint was major complication within 90 days related to the procedure. They enrolled 67 patients, most of them with cholangiocarcinoma or gallbladder cancer, and most of them were considered palliative only because either metastatic or with locally advanced disease. The interesting results, first of all, no cases of cholangitis. There were 2 patients with cholecystitis and 3 who required a second drainage attempt, which brings us to a reintervention rate of 15%, very low 90-day mortality, 13%, and of interest, 70% of the patients were able to perform systemic chemotherapy after drainage, which is definitely different compared to their historical cohort on ERCP. And also, retrospectively, they found that the overall survival was much better after percutaneous stenting compared to ERCP. Obviously, this is just a retrospective analysis comparing the 2 results, but this prompted the authors to put forward the data and start this randomized control trial, the Tesla study, again comparing primary percutaneous stenting versus ERCP, primary endpoints, 90-day complication and overall survival in the palliative setting in patients with hilar biliary obstruction. They plan to enroll 162 patients in different centers, mostly in the Netherlands, and the accrual right now is around 20 patients. So this is most of all our thoughts, our ideas for future investigations, some food for thoughts, I would say. And I would like to thank you very much for your attention and just leave the podium to my colleagues to start with the voting session. Thank you very much again.
All right, so really amazing presentation from Dr. Bagellini. I'm gonna take the opportunity here, since she's not here with us today, to ask Dr. Gate from our working group if he has any comments about what has been presented so far before we move to the voting statements. Terence.
Sure. Can everybody hear me? Yeah, I think so. That was a great presentation. I think the big things to underscore here are the fact that biliary decompression involves invasive procedures, so we want to be really judicious in how we apply them. The important aspect of that is they are critical. It is a critical component of care for patients with cholangiocarcinoma, and the fact that we just don't really understand which patients are going to benefit is critical because it improves overall health in the appropriate patients. It improves comfort because it relieves pain. But maybe most importantly, it's a critical procedure in enabling patients to get the treatment they need in the form of chemotherapy or other forms of therapy. And so identifying which patients those are, and then identifying factors that can identify how we most effectively can realize those clinical endpoints are things we just don't have information for. And I think Irene did a really good job of demonstrating that there are pieces of data that point in certain directions, but we really need to flesh that out to understand how we can optimize this therapy and get patients the treatment they need, which they're not getting to.
Okay, so going on to the first voting statement for the biliary decompression, we have developing quantitative methods to predict the therapeutic success of biliary decompression and malignant biliary obstruction is a key research priority.
Maybe if I can just ask a quick question before polling. I mean, I agree, it was a fantastic presentation. And I think in terms of developing the quantitative methods, the presentation showed radiology-based parameters. From clinical practice, we know that a same patient or two patients who have the same level of bilirubin, one patient will have the itch, a lot of itching, and another patient with the same bilirubin has no itching at all. But you won't tell that from the CT scans. So how are you going to incorporate the clinical input in the quantitative methods?
It's a great question. I think when we elaborate that question, we're coming from the assumption that the patient was presenting with symptoms associated with the biliary obstruction. But you are absolutely right. There are situations where the patients might have a blood exam with a bilirubin being high, and the patient has symptoms associated with that. But I think the other side of the question was how we can predict the patients who have a high bilirubin level. If they received a biliary drainage, are we going to be able to bring the bilirubin level down to a point where they can receive systemic treatment? I think it's kind of implied there. Maybe we had to be a little bit more clear about that.
Okay, so shall we move forward? Oh, Dr. Gores.
I like Juan, I don't really understand what the quantitative endpoints are here. So they can be symptoms, they can be nutrition, they can be bilirubin levels. But until we have better quantitative ways to assess bile flow through imaging studies, and we can select how many segments you need to drain, we're always going to be an issue that we won't solve. So I don't think you could do this based simply on imaging parameters without a functional endpoint.
Yeah, no, it's very well taken. I think, again, when we developed the question, was more about patients who were in need of a biliary drainage. There was a clinical indication for that. And unfortunately, we know that many times we do the drainage, the patients, they do not respond. And we lack, as interventional radiologists and endoscopists, a method that we can actually take a look on. Imaging-based analysis would be, on that case, for that question, functional liver remand, total liver volume, and try to correlate the percentage of the liver that we're draining with potential therapeutic success. So as of now, just for clinical context, when we receive a patient to have a biliary drainage, we do a visual inspection sort of like qualitative assessment of the CT or the MRI scan and see how much of that liver we can drain with 1 or 2 biliary drainages, and based on that, we see if the patient is a candidate for the therapy or not. So, as an interventional radiologist, my feeling about that question is that we do miss a more objective way of triage patients for going to biliary drainage. I think that was the main spirit of that question.
Microphone on the table here, please.
Does it work?
You good?
Can you hear me? Is that better? Yeah. We do have a quantitative endpoint in terms of what we need to lower the bilirubin to be able to get patients to be offered chemotherapy. And so I think having that number and correlating that with some of the features that we can assess by imaging could be really powerful. So having that quantitative endpoint, I think, is really important.
Thank you. Bess, very happy you're here. Please.
Thank you. Of course, I'm honored to see your presentation about the Tesla trial that we presented here 2 years ago. I just wanted to add, just for clarification, it was not a retrospective series. It was a prospective clinical trial. And more importantly, I wanted to point out that with this percutaneous stenting, there's not really a downside to putting 2 or 3 stents in. Increasingly, we do 2 or 3 stents percutaneously in the palliative setting. And since we have 0 cholangitis, the benefit is that during treatment, when patients get progression, very frequently the tumor grows up in the biliary tree. And if you just have 3 stents, you're just less likely to require additional stent placement. So with this approach, more stents is typically better. Of course, we don't ever drain segments with portal vein obstruction or atrophy.
Excellent points. Let's move on to our voting.
Next slide, please.
Can we move to the next slide? Okay.
So I'm going to read that again. Developing quantitative methods to predict therapeutic success of biliary decompression in malignant biliary obstruction is a key research priority. I will try to see if we could answer that on the basis that the number 1 patient has been clinically eligible and in need of a biliary drainage. And number 2, we're talking about quantitative methods mainly based on imaging analysis. All right, no consensus here. We are 14 minutes out of the end of this session. Dr. Valle recommended one slight change on the recommendation. If we change developing quantitative for developing robust methods, Juan, you want to elaborate on that?
Yeah, so I think by just going to robust methods, it would imply then we include additional data, not just what we're seeing on the imaging. It is a little bit vague, but I think the intention would be that we would include some of the clinical data that was referred to.
All right, so can we...
Hold on. course.
To achieve continuity of the intrahepatic circulation for the patient.
Sorry, can you repeat that, please?
Yeah. When is it not to the patient's advantage to establish continuity of the intrahepatic circulation? It's always advantageous. So I don't know why we need to. Is it to technically help the decompression, but the goal should always be decompression?
Yeah, but there are situations that we cannot do the decompression for technical limitations. Technical reasons, correct, yeah. Terence, you were about to say something?
That's what I was about to say, exactly, I think.
All right, so let's...
Thanks for bringing that up. That's a really good point.
Is there anyone else who has wording changes? I think that, then let's go ahead and vote on the new wording.
Right, we still haven't achieved consensus.
So we're going to move on to the next recommendation, and we'll put this on further discussion in the future.
Leslie, you want to read the next question?
Okay, second question or statement, optimizing patient selection for endoscopic versus percutaneous transhepatic biliary drainage represents an important research need.
Just waiting for the push. Push has arrived.
We can close the poll at 15 seconds too, just to save a little time so we can move on to discussion. All right, so we don't have consensus. If anyone would like to stand up and explain if a disagreement.
Sure. I could resist. I think because so much of this is based on local expertise, which is the issue. So it's a technical procedure. You have skilled interventionalists doing this, and they vary across the world at the municipality. If you look at the data from Nagoya, which has the largest experience in resecting perihilar cholangiocarcinoma, the data show that endoscopic drainage gave them better results than percutaneous. Others have argued and shown data the reverse. So I think at the end of the day, it's going to be the best local expertise. I don't think it's a research priority.
Does anyone have a comment that they'd like to change it that they think could strengthen this before we move on to the next question?
Just want to reflect on that I do think it is important because, for example, the Nagoya experience, they never published on the vast majority of patients who do not proceed to resection. And also, they've never published any endoscopic drainage, as far as I know, about the palliative setting, which is the vast majority of patients. So, and with the published literature on endoscopic biliary drainage, the cholangitis rate is above 50%, and the mortality rate is 1 in 3. And these results are so bad that I invite everyone who has better results to publish, because you'll have published the best results in the literature.
I think one way to address this, it is an important technique to be studying, but I think the third recommendation of the group is the strongest, that comments on developing better techniques, and we don't need to have a separate recommendation for patient selection of this particular technique.
Right, I agree that we can probably move on to the next one, but one quick question.
With a similar comment, there are also alternative endoscopic, such as echoendoscopic ultrasound guided drainage, which are not included in this statement, but might be in the third, and it might be better to...
So unless there's another real reason to change this in some way, let's move on to the next innovative type recommendation.
Okay. Innovating biliary drainage techniques to improve quality of life, minimizing hydroelectric.
We move this slide one. Thank you. Thank you.
Minimize hydroelectrolytic losses and enhance patency remains an unmet clinical need.
Okay, can we have the push? Great.
Push has arrived.
I think we've reached a plateau with the poll. A lot of abstentions.
I think one thing just to kind of incorporate all the comments from the previous one is we were altering the statement just a little bit to include at the end of enhanced patency to include optimizing patient selection, to incorporate that second bullet that we skipped.
I wonder if this is really just an abstention issue in terms of proportion, but could anyone who disagreed and would find a way to wordsmith this?
So the suggestion was to add and optimize patient selection after enhanced patency.
Yes, please.
I think I just want to make a comment about the wording in a lot of what has been put forward. I think if you ask patients to vote on minimize hydroelectrolytic losses, I'm not so sure that they're going to understand what that means. That's one comment. And I think for some of the other recommendations back along, again, some of the wording is quite vague. The one at the very beginning about radiology, there was a comment about, in the very first line, it was about diagnosis, heterogeneity, and there was a third thing, I think it was about lymph nodes, so there was 3 things within the sentence that you were being asked to vote on, whereas I think it should be clearer and 1 point within each recommendation. It's just a comment.
Thank you. So we have 4 minutes left, and we have another recommendation, so could really use a specific change to the language that would push this over the edge to consensus.
I agree with the comments that have just been made, that the issue is with
why are we making these improvements and trying to pin down exactly what to expect? The way to change it is just to improve patient outcome and leave it at that.
So I think, just to give the perspective of the working group, I think the way that we wrote this question was more in line with the Tesla trial and the really nice work that they're doing there. As a clinician, the way that we're doing biliary drainage hasn't really changed in the last 20 years. And a lot of our patients, actually the number is 40% of the patients who receive a percutaneous biliary drainage, they come back before the anticipated time because of issues with the drain, either infection, leakage, or obstruction. So I think, from my perspective, new techniques like the ones that are being applied on the Tesla, they are really transformative for the patient care and by consequence, the quality of life of those very same patients.
Can I propose that we vote again and maybe just take out minimize hydroelectric losses, because that kind of is incorporated in quality of life, I think, and take a revote?
Thank you. We're just sending the rewording.
Quickly, if you would, while we're
Humbly speaking, I'm just a pawn in this mix, but I am on the patient side, and I'm in the minority of patients with cholangiocarcinoma. I believe I am part of that para-highlight group who did have to go through the stenting, the percutaneous stenting, and I just told my wife it was absolutely miserable just because of the leakage issues. The drains kept getting infected. I had to be hospitalized for sepsis. So I feel like, to me, having gone through this, that this makes sense, that it's to improve the quality of life. It is an unmet clinical need, and hopefully developing an innovative drainage technique as an alternative. I don't know. Like I said, I'm just a pawn in the mix, but that's just my take on it as a patient who's gone through some of this.
So thank you. Let's vote again with that one small change.
All right, so we are revoting. Innovating biliary drainage techniques to improve quality of life, enhance patency, and optimize patient selection remains an unmet clinical need. And maybe we can vote in 45 seconds to keep going. Yeah.
Right, I don't see too many more votes coming in, so vote now. There we go.
Thank you.
Yay.
And on to our last recommendation.
We have Vincenzo Cardinale, who's going to give us just a quick update or discussion on review of available resources. I know we're over time.
Thank you very much. It's a big honor for me to be here, and a big pleasure. As presented already by Professor Vallée, there are already many existing resources to boost and develop multi-center research that has been promoted by Cholangiocarcinoma Foundation and International Cholangiocarcinoma Research Network. So for the patients, there are many possibilities to do collaborative study, collaborative project, because there are many tools, many resources that are available, but the importance is to align, to harmonize this, to give a direction, and this is what I saw in the morning the foundation is doing, but also in Europe, some other initiatives are going on, and this is the reason I'm presenting today this initiative. Something that is interesting, that as the perspective of a clinician, as a scientist, change a lot with respect to your expertise, whether you are an oncologist or a gastroenterologist or a pathologist, but the journey of the patients is what is really matter. So no matter what are your perspective, you have to be focused on the journey of the matter and perhaps make different questions, but try to optimize the data because the disease is all the data need to be optimized. We need to optimize the resources that we really have. And I think that there is a lot of synergies when we put together oncologist perspective and clinical gastroenterology and the other radiologists, because the different questions bring new data, and the data at the end create like a synergism. And I'm happy to say that we are among, and we are creating all together, in US, the foundation, in Europe, like an ethical alliance that are very focused on the patients. And this is really, really important in order to face our challenge. So, in Europe, what is going on, Professor Vallée already presented the history, a little bit of the European Network for Study of Cholangiocarcinoma, that this year is more than 10 years that was founded by a bunch of persons, friends, Jesus Banales, first of all. And you see, it is envisioned like a different database that can be interacted, can be really talk each other, and can create the opportunity to gain insight into correlation of clinical aspect, molecular aspect, or histology, and so on. So I have to go very fast, but this is an ongoing and important effort, collaborative effort, that the primary aim is to determine and monitor the presentation and management of patients with CCI to improve the diagnosis, classification, treatment, and prognosis of patients. As you can see here, it is a retrospective and prospective data capture. It's coordinated by Jesus Banales, that is here with us, and founded and coordinating this project with other collaborators, Laura Ischerardo, and with as you can see here, with many collaboration with different parts. Will go very fast. Actually, I will show how many patients are there, more 6,000 patients, many publications. Okay, I will skip everything. I want to mention this is important.
If I might suggest, I think the best thing would be to go forward to the recommendation, and then you can elaborate a little on why that recommendation has its strength.
Yeah, okay. Okay, I will go. So it's histological registry, radiology registry, and then other resource that has been there for the Precision BTC network. And the recommendation is quite simple. I mean, I think it's very general. And I would like that the NARCI can read this, because I think it makes sense that the NARCI can, if you can read, please, because I think it makes sense, because it's so general. Please.
So the consensus statement: there is a need to implement a coordinated effort among multiple parties to optimize data collection, sharing, and utilization for multiple purposes, comprising the development of regulatory approved, safe, and effective diagnostic and therapeutics.
And I think in the morning we have discussed a lot about this. It is interesting that this statement is at the end of many discussions about implementing the registry, implementing collaboration, also for a regulatory issue.
Okay. Yeah, I think this recommendation is really important, because that's one of the ways that we can actually do something actionable about the research on cholangiocarcinoma, and also address the challenge that we have right now with regulatory, like for instance GDPR in Europe, and material transfer agreements between institutions and so on. I think the idea here, and for me, reading sounds quite obvious, and I don't want to, scoop people towards one answer, is that we really need to do a coordinated effort under a society, ideally, where we can, get all those very valuable data together so we can move the field.
So let's go ahead and open the poll.
Okay, so we're waiting for the push. It's arrived.
And we do 45 seconds, if that's okay. We stop at 15 seconds.
Yeah.
Okay, I think we can close the voting now.
Very convincing words, Dr. Cardinale. Appreciate that. Thank you.
That was a fantastic first session. We got through 8 recommendations. I think there's a lot of fantastic dialogue. So I think that we've really set ourselves up for 3 fantastic days.
Thank you, everyone. So we reached consensus on 6 of the 8 recommendations, which is great. We're now shifting to the patient and caregiver perspective, and we'll be hearing from Dana Fox, who is a patient advocate from Canada.